This is the International Academy for Clinical Hematology around the globe and across the hematology field. It is 7 p.m. in Paris, 6 p.m. in London, noon in New York, 8 p.m. in Istanbul, 7 p.m. in Hamburg, 7 p.m. in Toulouse, 7 p.m. in Nantes. And it is my great pleasure to welcome you all to this post IMS summary or take-home message webinar. As you probably know, after each major or key hematology event, the ICH organize a webinar, a wrap-up webinar where top experts in the field are going to give you their thoughts, their take-home messages, their interpretation of the presented data. And today, joining me is a distinguished faculty, namely Dr. Lisa Leypoldt from Hamburg, Germany, Dr. Meral Beksac from Turkey, Dr. Aurore Perrot, Toulouse, France, Dr. Nizar, Bahlis, Calgary, Canada, Luciano, Costa, Alabama, US, Saad Usmani from Memorial Sloan Kettering, New York, Jean-Luc Harousseau, Nantes, France, and of course, our awardee, the Waldenstrom Award awardee. We're very proud having with us tonight Dr. Thierry Facon. So these top experts have participated to the IMS, which was held in Rio, in the beautiful city of Rio de Janeiro in Brazil. We had a wonderful time, a very warm hospitality, fantastic food, but also superb social events and friendship. But for the time being, I think we need to focus on the science, and I will try to structure the discussion around the key topics that were discussed and debated during IMS. But of course, the audience is always most welcome to contribute by questions, suggestions, comments, whatever you would like to share with the faculty. I'll be more than happy to take these messages. So my first question to all of you guys and whoever wants to volunteer to start is about the new high-risk myeloma definition. We've been hearing about this, the famous workshop in Barcelona last year. We're still waiting for the final publication, but I think now it looks like the definition has become mature enough. And maybe I would like you can share your thoughts about first, what is this definition, and maybe what are the implications of this definition. And I'm very happy that we have a designated volunteer, Saad. The floor is yours.
Thank you so much, Mohamad. It's a privilege to be here with all of you. We've had a very busy, meeting in Rio and a lot of updates. To answer your question, I think one very important point before even we define high risk is, that definition will continue to evolve and change. And we have such an amazing time in myeloma with new therapeutics that we hope that some of these therapies will even overcome, these new changes. So, going back to the Barcelona meeting, what was given to us as a charge is, can we identify true biologic high risk in the context of, modern therapy? And several groups contributed their data sets in coming up with this definition. There was some consensus involved. So, for example, for deletion 17p by FISH or p53 deletion by next-gen sequencing, there was very clear consensus around that. I think, the consensus around certain high-risk translocations, such as 414, 1416, 1420, the consensus was you have to have either a 1Q gain or 1P deletion to go along with it. So that was, the second piece. then biallelic deletion of 1p, with or without a 1q gain was, the third one. The fourth was very interesting actually, because it's more of a marker of potential biologic high risk. It was beta 2 microglobulin being higher than 5.5 in presence of normal renal function. I think that was the important part. And there was a lot of back and forth amongst the groups around that, and it was primarily because that can be a marker of more proliferative disease. That can be a marker of patients presenting potentially with extramedullary disease presence or more aggressive, clinical phenotype. And so, for now it's in, but the real key was, can we identify true high risk based on disease biology? But then, I would welcome comments from Nizar, because, I know we've also talked about, what would be the immunologic high risk, features that we need to potentially incorporate in the future.
Nizar, you have no choice. You've been designated to be the second in line.
Hi, everyone. No, I agree with Saad. I mean, Saad covered the key point about the genomic or cytogenetic features of high risk, which has now been revised, mainly to reflect the 1p loss coupled with 1q gain, and when it's coupled with other translocation. I did present on this topic at the meeting about the shortfall of this classification. And one of the shortcomings of this classification, it doesn't include the immunological signature into the risk definition. Many of the therapies we use today include therapies that revamp the immune system, and hence this might not necessarily apply in the era of immune-based therapies. In particular, for example, if we look at the most bispecific antibodies trials, the cytogenetic classification don't seem to reflect poor outcome in these patients. It's not clearly the cut with CAR T cell therapy or with anti-CD38 based therapy, where 1Q, for example, still appear to be high risk features. So for now, we've made progress with the new classification, but I think we're going to see more iteration of classification as we learn more about the risk involved with immune-based therapies.
Thank you, Nizar. So it looks like we have the biology of the disease, and this is a traditional definition. Now you're adding another layer of complexity about the immunological signature or footprint. But then that brings me to the issue of the dynamic risk based on MRD. And I think we'll come back later to this. Dr. Perrot presented on behalf of the IFM, which I think one of the highlights of this meeting, the first results of the MIDAS trial assessing risk based on MRD. So how would you fit the risk with the MRD evaluation? Because some very high risk from a biology standpoint can achieve rapidly MRD negativity. And then is this going to bypass or overcome the risk? And then, of course, my next question, probably for you, Lisa, saying, what are the therapeutic implications? Because you published this famous concept, a study dedicated to high risk. So who wants to take the MRD part of the story? Meral?
Well, I mean, the primary authors are here, and Luciano is also here, an MRD expert. But I think the last word, the final word, is that even in a setting of MRD negativity for a high-risk patient, that concept is not the same as a standard risk patient with reaching MRD negativity. So those two have to be taken into account. And when we look at the different quadruplet studies, Perseus, even in the maintenance study, the Auriga, you see that there are some subtle differences in the same treatment between patients who are standard risk and high risk. So quadruple therapy is not able to overcome, but maybe the concept study and the MIDAS study, they might have deeper data that can give more concrete answers to these questions.
No, thank you, Meral. But this is interesting what you're saying, because I've seen a couple of slides during IMS, which were, in my opinion, controversial, maybe suggesting that MRD negativity can overcome the risk of the biology of the disease, which apparently you don't agree with. So, Lisa, what do you think from a therapeutic perspective, the implications of this new definition? Should we run again the concept trial and test the validity of these criteria?
That's always, well, that's a provocative question. First off, I'd like to I totally agree with Meral that the concept of achieving and maintaining MRD negativity requires different efforts in standard risk and high risk patients. So as we see in several trials, and I mean, especially Master has shown it, just achieving MRD negativity doesn't prevent high risk patients from relapsing. You actually have to maintain treatment. And that's, I think, some of the success stories of trials such as Concept, but also UK Optimal or others, where we have this intense maintenance with several agents trying to really keep the treatment pressure on and trying to prevent the disease. Regarding your question on the new definition, I think, well, of course, our trials and others, we will see if and how we can sort of reflect the new or look for these new criteria in our cohorts, but that's not always possible due to prior not testing for some of these criteria. But these high-risk trials, their criteria maintain validity in my eyes, because it is really a high-risk cohort as it was defined by then, and we heard earlier that the definition just naturally changes and will change over time. And I do not think that it makes sense to do the same concept in this new high-risk cohort, because we can see, even though it is quite effective, that it's still not effective enough for some patients, and we need to get better anyhow. So I think do not run it again, but try to improve even further.
Thank you, Lisa. So, Jean-Luc, what is your perspective? How should we wrap it out when it comes to all of these parameters?
You are on mute.
Yeah, we need to yes.
Okay, I would like to make a comment on the interest, the practical interest of this new classification of high-risk disease. I think, of course, it might change in the next years, but currently it's very important in order to compare clinical trials. And when looking at the 3 clinical trials which were focused on high-risk disease, the Optimum MEC9 from England, the Concept, and our own trial, the criteria for defining high risk were different. And if I speak only of the French trial, which yielded very good results, the criteria were, I would say, classical: deletion 17p, translocation 414, translocation 1416, and probably many of these patients would not have been classified as high risk with this new classification. So I think it's very important, because with the quadruple therapy, we can reach very good results, and we will discuss the MIDAS results, which are, of course, quite comparable to those achieved in the high-risk focused trials. So it's important to know what we are speaking about and to use this classification for better comparing the clinical trials. And I would like to ask Aurore to comment your question about the interest of the dynamic prognostic related to the response to treatment, because clearly in the results she presented, there was a great difference between MRD achievement and cytogenetic classification, with a curiously patient with translocation 1114 achieving less MRD negativity than high-risk patients. So I would like to ask her what is her opinion about this surprise, and shouldn't we wait for longer follow-up in order to know what it means?
Yeah, thank you, Jean-Luc. So obviously, I would kindly ask Aurore maybe to summarize actually the MIDAS results before going into the specific issue, because at the end of the day, I guess the concern and the idea between the lines is, are we maybe reducing therapy or downgrading therapy in those patients who actually deserve to be to have more intensive therapy, and vice versa? Aurore, what are your thoughts?
So first, I fully agree with Jean-Luc regarding the possibility to compare the clinical trials, because we all are doing that, and we compare not always the same patients. And the second point for the new high-risk definition is that sometimes, and we did it in the MIDAS trial, we define the high risk according all the definition, and we have seen that the proportion of high risk is very different. And I think in 2024, we can't say that 40% of the patients with newly diagnosed multiple myeloma are high risk. And the new definitions with about 15 to 20% is enough, to my opinion, because when you look at the curves of PFS and OS of the Perseus trial, for example, we can't imagine that 40% of the patients are high risk. So regarding the MIDAS trial, the results we presented are very early, and we were surprised to see that there is such differences in MRD achievement between the cytogenetic subgroups. But first, we don't see any difference regarding the risk, high or standard risk. Neither with ISS and revised ISS, LP score, and nor the new definition. But we observe that in such particular subgroups, and especially translocation 414 and translocation 1114, we have very different results. And I think we have to learn, because we don't know the correlation of achieving MRD negativity very quickly after induction and the long-term outcome. And I'm sure that the results will not be the same after transplant and after consolidation. So just we have to wait.
So here, as a reminder, Aurore, for those who are not familiar with the MIDAS trial, everybody in this trial, these are young, fit, transplant-eligible patients. They got ESAC, KRD, isatuximab, carfilzomib, lenalidomide, dexamethasone, 6 cycles of induction, irrespective of the biology of the disease. And then they split into 2 groups. And then within each group of biology risk, they go into MRD positive versus MRD negative. And actually, after 6 cycles, you have a very, very high rate of MRD negativity, which is absolutely great in my opinion. But Jean-Luc, you wanted to comment on this.
No, you can tell the rate. It's 63%, and I think it's very, very attractive. No, I just want to make a comment regarding those patients with high-risk cytogenetic, let's say deletion 17p, who achieve MRD negativity. They will be randomized between transplant or no transplants. While currently, patients that we consider as high risk, they are candidates for receiving at least 1 autologous transplantation. So that is the reason why it will be very interesting to follow this trial and to know what will be the outcome of those patients who are considered as good risk because they answered rapidly, while they were maybe high risk because they had high risk cytogenetics. To be probably very interesting.
That's going indeed to be, yes.
Sorry, I'm wondering a lot for patients with the translocation 414 and classified high risk, and more than deletion 17p, because there is a lot of patients with translocation 414 who achieve MRD negativity. It is not the same with deletion 17p, but of course, and you all in the HiFM group remember all the discussion when we design the MIDAS trial. And we have a lot of discussion and regarding cytogenetics or MRD. If I have to do a MIDAS-2 or another trial today, I think I will consider both criteria and de-escalate only patients with standard risk and MRD negativity, but it's more easy to say today.
Thank you. So I'll hand it now to Luciano Costa, because Luciano, you have, I think, run one of the first trials looking into MRD driving treatment. And one of the teaching of the so-called master trial was that we should not maybe downgrade the treatment in the high-risk cytogenetics, even if they achieve MRD negativity. And I think this is the story of Aurore, who is now anxious for some patients in the trial. So what's your interpretation of the data, and how do you handle this story now based on the knowledge achieved here and there?
Yeah, I think that those are very important points, Mohamad. And I think the reality is there's two things that interplay. That is the biological risk of the disease and the depth of response. And we know they both contribute to the overall final end outcome, and one does not trump the other, at least not completely. That being said, we need to remember we're coming from a paradigm that everybody gets the same treatment regardless of risk or depth of response. You know, we just saw Perseus' fantastic data. We all celebrate, same thing with Cephals, but let's remember those are still trials where everybody gets the same therapy regardless of risk, regardless of depth of response. So any change in design that accounts for depth of response or accounts for risk is definitely a step in the right direction. It's impossible, at least I think it's impossible, to have a trial that perfectly adjusts for every single one of those elements and not be criticized, right? So I think MIDAS did what I think is a fantastic step, which is acknowledge how crucial MRD is in interpreting future outcome, and choose to ask different questions for different MRD subsets. And that's going to come with caveats. There are going to be some high-risk patients who are going to be randomized to no transplant, and there might be some standard risk patients that get tandem transplant. But that is the price to pay to have a trial that is at least account, rightfully so, for some component of risk. And the other thing that we have to keep a kind of a humble attitude towards is how we know about the risk is based on prior therapies. And as we introduce new therapies, the risk of change, the idea of risk completely changes. I think a good example is isolated 414, which I really believe, and I think the data shows in the era of quadruple therapy, might behave just as well as a standard risk disease. What we saw in MIDAS, 63% of MRD negativity, is the highest MRD negativity rate post-induction of any therapy we have ever seen, because we had very potent agents and had an extended duration. So I think we need to say, well, we should not compromise or challenge the validity of this study based on preconceived notions that were informed by trials where most people are getting doublets or triplet therapy. Now, regarding the high-risk patients and the cessation of therapy, I think I agree with you. We learned from many trials, including MASTER, that those patients have a higher risk of recurrence despite achieving MRD negativity. It so happened that in MASTER, they had many of those patients cease therapy, but I would be cautious to assume that the recurrence happened because they ceased therapy. We see, for instance, on the CONCEPT trial, where patients stay on therapy with both the PI, IMiD, and a proteasome inhibitor, and very potent one, and you still have a very high rate of recurrence despite continuing those therapies. It's like 50% at 3 years on those with 2+ high-risk chromosome abnormality. If you look at the Perseus trials, the cytogenetic analysis also presented IMS. Those patients with revised ISS2 stage 4, which is a good surrogate for tumor high-risk abnormality, they still have about 50% of those patients progressing after 3 to 4 years. So I think this is a group of patients that we're going to need something new. I think it's totally accurate to say, they are still have an increased risk of progression despite achieving MRD negativity. It's probably not the prime population to look for treatment cessation, but I'm a little bit skeptical that just a different combination of the same agents we have had would make an impact on those patients. I think we need some experiment with new drugs with new mechanisms of action.
Thank you, Luciano. Meral, you wanted to comment on this?
Yeah, so I wanted to echo what Luciano has already said. It's about the Harousseau study during the IMS. We presented the impact of cytogenetic, not based on the traditional criteria, but also merging the one or two more high-risk features, the way it was done in masters. So it's a kind of a transition towards the new high-risk criteria, and there it is possible to see the impact of, the quadruplet is effective all through the risk groups, but the impact of the quadruplet becomes less and less in the advanced high-risk groups. And there's a distinction between PFS effect and MRD negativity effect also. So I think there is the role of the doublet maintenance, which has been continued until sustained MRD is achieved in this particular study. So in future, we will be able to see the impact of this very high-risk patients, how they behave, if they follow what we have been already telling based on our earlier experience.
Thank you, Meral, and you made my life easy because you introduced a second chapter of this discussion. And this is, I think, many of our colleagues watching us today are looking forward to hear from you guys. What should be the standard of care, for instance, for a transplant-eligible patient today? What would be the optimal induction? How would you perform transplant? What would be the maintenance? And let's start with Saad again, because based on all the novel information, I think we should have a sort of a standard algorithm for the time being while looking into these different questions of risk and MRD assessment.
Yeah, I would build on everything that we've been discussing so far. I think there is clear alignment based on data that quadruplet induction makes the most sense for transplant-eligible patients, and we can, pick our anti-CD38 or have a discussion whether bortezomib or carfilzomib would be better. But I think the quadruplet induction gives us the best depth of response, pre-transplantation for patients. So I think that's very important. I think autologous stem cell transplant does remain, the standard of care for all eligible patients. The kind of median the PFS and OS rates that we're seeing at 3 or 4 year mark with all the existing quadruplet induction trials in that setting are really remarkable. So that's one thing. In terms of maintenance, I am getting more comfortable with the idea of dual drug maintenance, even for standard risk patients. But what we have to really figure out is which patients would benefit from a single agent only, which patients would actually benefit for two maintenance drugs only, and do we need to continue them forever? Can we just stop after sustained MRD negativity? I think those are the key questions for that patient population. And of course, Mohamad, you only asked me to comment on the transplant eligible ones, so I'll stop there and we can come back to the subsequent discussion.
Of course, the debate is maybe about the quadruplets in general, but I think we need to enlighten or at least give some guidance to our colleagues who are not attending on what is the current standard of care. Jean-Luc.
Microphone.
I'd like to comment on the maintenance treatment. I think that there is a consensus regarding the maintenance treatment for high-risk patients. It's rather empirical because there is no real proof, but I think everybody thinks that it's better to give a combination of lenalidomide plus, and usually now it's lenalidomide plus an anti-CD38. But for the standard risk, I'm not so sure. If we look at the Perseus trial, the design of the study is that patients in the DARA arm receive DARA maintenance. And of course, they have the best PFS. But we don't know what would have occurred if those patients in the DARA arm would have received len alone. I think that we really need a direct comparison after transplant between the combination DARA-len and len alone, which has been done in the Auriga trial and which is in favor of the combination. But the problem is that in this particular trial, patients initially treated with the anti-CD38 were excluded. So with the current treatment, which includes anti-CD38 from the very beginning, induction consolidation, we still don't know. There is still no evidence that the combination with DARA is useful for those patients who did receive daratumumab up front.
Wonderful. So, Jean-Luc, you're introducing another important trial which was presented during IMS. This is the Auriga phase 3 randomized trial presented by Dr. Badros and colleagues. And it's like a very nice proof of concept comparing DARA-len versus len as maintenance. But as you highlighted, the biggest weakness is that the field is moving very rapidly, that by the time we got these results, positive results, actually we're using now anti-CD38 frontline. So Lisa, you wanted to comment on this.
Yes, thanks for bringing this up. And I would like to totally agree with what Jean-Luc said, and just bringing to mind that I think we will have some answer to this question, but we will have to wait a little longer because the GMMG HT7 trial is actually investigating this question because of its second randomization. So for those who are not familiar with it, it's RVD or versus ISA RVD in induction and then transplant, and then followed by a second randomization, len maintenance versus ISA len maintenance. So this will, by the time we will have some data on PFS and overall survival and stuff, this will actually help unravel this question of the value of CD38 plus len maintenance after triplet or quadruplet induction. So I think as of now, we cannot say if it's really needed for all the patients or for whom it is needed. But yeah, I guess just we have to hang in there.
Meral?
So in the Auriga study, if you look at the forest plot graphs, it shows that both the high risk and the standard risk, they benefit from the doublet. But I want to ask you, I have some people here in the Cassiope, initially, those patients who didn't, in the maintenance, who didn't receive DARA, if they had received DARA frontline, they were doing better. With the updated results published this year, there seems to be a difference, but it's not so big, and the sample size does not allow to compare standard versus high risk. But so we don't still have sufficient data to make a conclusion. I mean, that's my opinion. I would like to hear yours.
So what you're highlighting, Meral, is that if patient received an induction, and if it is like a long induction, the magnitude of benefit of adding an anti-CD38 maintenance is not going to be for you clinically meaningful. But I don't know, Luciano, would you agree with this conclusion, or you would be willing to take whatever benefit you have?
No, I totally agree. I think if we have to think in mind that this huge benefit that we saw for lenalidomide was at a time when there was much more territory to be conquered, right? Because recurrences were very common in the first few years after you did a doublet in an autologous transplant, which is really the data that supported lenalidomide. So now, if you just look at the Cassiopeia patients who got DARA VTD, transplant DARA VTD, and no further maintenance, The PFS is quite reasonable. Looks far better than far better than doublets plus land maintenance. So there's much less territory to be conquered than there was when we studied maintenance 15 years ago. So whatever has a benefit in that population is going to be a small benefit in absolute terms. I have a little bit of a kind of a rhetorical point that I make about this. We all agree that, well, LEN is the way to go. Let's see if a monoclonal antibody is needed. But I like to kind of flip that assumption, because if you think about this, for patients who get quadruple induction and consolidation, what randomized data we have for any maintenance of any kind? And the only that we have is data versus observation on Cassiopeia, right? The only randomization that I'm aware of for patients who receive a quadruple induction consolidation. And the benefit of data is there. It's not huge, but it's significant. So the question becomes, which is a question that nobody's going to answer directly, but does LEN add to anything to data? And I think probably does. We're gonna learn that from we're gonna extrapolate the benefit of knowing the synergy of LEN. But if we're gonna go by what the strength of the evidence, it's hard to ignore the benefit of more extended monoclonal antibody therapy. The problem with high risk is a bit tricky. We always default to trying to give more therapy and prioritizing the higher risk patients because, of course, they need the most. But I kind of often invoke what I call the Palumbo principle. I remember Dr. Palumbo saying, and it stuck with me in my early days that I don't ever forget, it's hard to come up with a therapy that is helpful to high-risk patients, that is not even more helpful to standard risk patients. And we saw that very well on the 3038, either in individual clinical trials, but also in meta-analysis. The benefit for high risk is there. It's just of a lower magnitude than it is for a standard risk. And that benefit, I think, tends to a little bit longer to show, either because you have a smaller population, so it's a problem of power. And I really think there's some very aggressive disease that is merging into high risk that is going to account for events in the first couple of years that you cannot overcome with any of the existing therapies. So I think that takes a little bit longer to find that answer, but I think the benefit is there, just less. Which I find kind of the flipping side of that is hard to deny that those therapies to standard risk based on the fact they usually enjoy even greater benefit.
Thank you, Luciano. I think nobody is going against the fact that DARA is a great anti-myeloma drug, and by having two anti-myeloma drugs, you're going to do better. And obviously, maybe we will be able to cure more rapidly the standard risks than the high risk. So if I summarize this discussion, and I'll ask Nizar to wrap it a little bit, is LEN is still the standard of care for maintenance, but then on a case-per-case basis, we probably need to consider, unless we have news about approval or other additional data, we should add an anti-CD38 like DARA. What do you think, Nizar? What's your practice today if a patient comes tomorrow to you?
Our practice, unfortunately, is limited by funding. We don't have currently funding for daratumumab maintenance. But I think the bulk of the trials, whether it's the Perseus trial, whether it's Cassiopeia trial, do suggest there's benefit from adding anti-CD38 therapy. The question, is it needed for all? Is it needed continuously? Is it pre-induction, post-induction? I think, as Lisa said, we need to avoid the HD7 trial, because there we have a double randomization. We have DARA pre and then randomize again to DARA with or without Revlimid. For now, in our practice, if a patient can afford to pay daratumumab maintenance, we offer it for somebody with high-risk disease based on the experience from the Emory group. And in that group, continuous therapy and more sustained therapy. And again, based on the benefit we see in the Cassiopeia for high-risk patients from adding DARA, even if you receive DARA pre. So I think in this patient population, there's benefit from adding daratumumab in the maintenance setting. with the exception for that, I think in the routine practice, we shouldn't be adding daratumumab randomly because biologically we may be adding more toxicity, we may be selecting more aggressive clones with CD38 loss. And in this patient population, we don't know the long-term consequences of that as well.
Thank you very much, Nizar, for nice summary and for your wisdom. So another important topic where it proved to be true that the more is the better is the elderly fit myeloma, where we're moving apparently to quadruplets. And we had earlier this year during EHA the results of IMROSE, isatuximab VRd versus VRd, showing superiority, benefit from the IFM, isatuximab RD being inferior to isatuximab VRd. And last but not least, we had Saad, who presented the results of the famous and highly awaited Cepheus trial, looking into Dara VRd versus VRd, and we are eagerly waiting for the publication. Here, I'd like to ask Thierry, because he has pioneered many of these trials in the last 35 or 40 years or so, on his view about the evolution of this field and your take-home message from IMS, Thierry, beside the sightseeing and the beautiful memories we had together about how to treat the elderly myeloma.
Okay. Besides the sightseeing was good, in fact, to be honest. Saad did a wonderful presentation on the Cepheus study, and what is amazing from my point of view is that these two studies are very similar, and so this is, from my point of view, something very important to highlight. And at the time, so Saad and myself, we saw the Cepheus results last June for the first time. And that was exactly the time I was presenting the IMRO study, and I had in mind all numbers of the IMRO study. And I said, okay, this is exactly the same. This is the same for, so if, for example, if you look at sustained MRD negativity for more than 1 year, this is 47, 48% in both studies. If you look at the duration of therapy in both arms, the median PFS of the VRd control arm. So even if you look at the grade 5 story, for example, it looks pretty similar. So Cepheus had a little bit more COVID, but these results are amazingly similar, I would say, and this is good news for patients. And you know, when we saw IMROSE for the first time, having VRd with a median PFS of 54 months was just considered to be unexpected, and Cepheus has 52. So okay, that's good, and I think that's important for patients. The other thing is that as you know, the US FDA has approved IMROSE just at the time of the IMS meeting, or just a few days before. And interestingly, they did approve without the age limit of 80 years. So Cepheus, you know, one difference between the two studies is that IMROSE excluded patients over the age of 80 years, and Cepheus has excluded patients, the frail patients, which means patients over the age of 80 years by definition, but some other patients as well, few other patients as well. So FDA has provided a broad approval, and I guess that will likely be the case for, so FDA will do the same with Cepheus. The only thing is that we do not know exactly what will be done by EMA, but I guess that EMA will likely do the same, which means that they will say that these quad regimens are good regimen for transplant ineligible patient. And if you have in mind that a particular patient at the age of 81 can get it, in fact, you would be allowed to prescribe these quad regimens. And and then, you know, after these two studies, I would not say that the debate is not closed, but at least 4-drug regimen will be approved for, let's say, elderly fit patients at the time of diagnosis, elderly fit in general. So you will have to make your decision on frailty or fitness, and just to say, this is not for this particular patient, but this patient can get 4 drugs. And then the next step, the other thing I would like to say is that the DRD is not dead, because I do believe that specifically for the frail patients and maybe some patients who would be concerned about neurological toxicity of bortezomib, because, for example, in Cepheus and IMROSE, you have 6 to 8% of patients having still grade 3 neuropathy, and so this is not an easy complication for all patients, but you could say even more for the elderly. So the DRD is still a valid regimen for the frail patients, and maybe for some older patients who would not accept to receive 4 drugs, or if you are not willing to prescribe 4 drugs. And then the next step will be the impact of the implementation of bispecific antibodies. So these studies are currently enrolling patients, but that will need time. So I think that these ISA or DARA-VRD and DRD regimen will remain on stage for some years, I would say. And with that, you know, we don't know about the median PFS, but the median PFS will likely be something over 80 months. And my last point is back to your discussion on LEN and DARA maintenance. The paradox, as you know, is that you are allowed to prescribe DRD for 100 cycles if you want. And the same is true for ISA-VRD or DARA-VRD. But importantly, and I strongly believe that if you can achieve median PFS 80 months with ISA-VRD or DARA-VRD, this is also partly related to the fact that these patients will remain on a CD38 on lenalidomide. And so I am quite comfortable for having a CD38 and len also for the younger patient as a kind of maintenance. I think this maintenance will have to be discontinued, but having the 2 drugs is not, from my point of view, is already acceptable.
But then that brings me to the issue is that the key benefit of the 4 drugs in terms of PFS is also related to a high rate of MRD negativity. So should we, and we in the so-called elderly population, we don't speak about the risk of the biological risk. We rarely discuss it. One size fits all. So here my question, at least because of this issue of continuous therapy, which is not maybe the ideal for some elderly patient, shouldn't we, at the era of quadruplets, start using MRD actually, and assess, similar to what has been done in the MIDAS trial, the issue of the value of MRD? Any thoughts on this, Meral?
So I was going to ask both Saad and Thierry of these quadruplet study leaders what they how they evaluate the benefit study, because in the benefit study, they adding the bortezomib, comparing without the bortezomib, the differences are so great. And what you're saying is, so for some patients, maybe there's a need, but in a modified version, how benefit is doing. So how do you evaluate the control arm of the benefit study with and the experimental arm?
Okay, I can take this one. So Saad has to say something, of course, but the benefit is an IFM study, and this the rationale. We say that so we had these VRD versus CD38 VRD studies on IFM side, okay, at the same time, but what would be the added value of the old bortezomib? So we did Lendex isatuximab versus ISA VRD. I think interestingly, if you look at, benefit is very concordant with what we know from CD38 lenalidomide and Dex. So ISA VRD is expected to be quite similar to the DRD. And if you look at the ISA VRD arm from benefit, which is a kind of VRD light. You know, you may find different VRD light regimens. So you will find a lot of VRD regimens, and you will find some. Okay, VRD light is not only one regimen. So we took one VRD light regimen, which is good. So at the end, we have a little bit less neurological toxicity. It was difficult to look at this at the time of the ASCO presentation, because Xavier did report on grade 2 or more, and we did report on grade 3 or more as usual. But we asked Xavier to investigate the grade 3, and so the grade 3 is something like 3 to 4%, which is, and we had 6-7% with the, let's say, the usual VRD. So you will have a benefit in terms of tolerance, and if you look at the ESA VRD from benefit, it's premature, because the follow-up is only, median follow-up is only 2 years, median follow-up of Cepheus and Imrose is 5 years, so it's not the same analysis, of course. But if you look at the 2-year PFS rate of ESA VRD in benefit versus Imrose, this is exactly the same. This is 85% of patients. So we do expect that both ESA VRD arm will likely do the same in terms of at least in terms of PFS.
So let me ask Aurore about standard of care today. We have Imrose, we have Cepheus, we have benefit. And we have to also acknowledge that the Perseus trial has a small overlap between 65 and 70, which, so you can add the Perseus trial into the debate if your cutoff threshold is 65 year. So if you have a non-transplant eligible but fit patient, what I heard from everybody is that the triplet anti-CD38 RD is a backbone. Then how are you going to manage? Would you be willing to add bortezomib to some? How do you identify these patients?
For me, if the patients can receive a quadruplet, the results of Imrose and Cepheus and benefit trials argue to give quadruplets. So in my center, we give ESA VRD since Thierry presented the results. So we have moved after 65 to 68. Nizar said the use of Daralen is depending on funding. Sometimes in my center, the use of transplant is depending on beds. But after 65 and until 75 at least, I would say I use the quadruplets, yes.
Okay, so let me be provocative and ask Saad, because you reported Cepheus, and Thierry insisted on the fact they should be old but fit. But if they are old and fit and can tolerate a quadruplet, probably some of them can tolerate a transplant. So this is a bit confusing for me, you know. We've been like schizophrenic. On one hand, we preach for this. On the other hand, we preach for something else. So how do you handle this dichotomy?
No, in fact, this dichotomy is more prevalent in the United States, perhaps, than, you know, in any other region in the world. So I think we have to pay attention to the patient population. You know, the patient population in Perseus, in Griffin, you know, are, you know, in all the transplant eligible populations are 10 or more years younger than in Cepheus, in Imrose, you know, in the benefit trial. So we have to keep that in context. And, you know, I feel that we certainly need to have a discussion on how best to implement frailty scoring in 70-plus-year-old patients and really revisit the role of transplantation for those patients, because we always extrapolate even in the US, and this is coming from a biology disciple. I think, you know, we need to revisit, you know, the role of transplantation and really adhere to the patient populations that we were studied in. So quadruplet makes sense, you know. I think that's fine, but 70 plus years, fit is very different than 60 years fit. And we need to recognize that and really move in that fashion and really, question the role of transplant in that older extrapolated population.
Jean-Luc?
Yes, can I ask a provocative question to Saad and Thierry?
Yes, you can.
Since the first trial, we know that for elderly patients, continuous therapy makes a difference. And I don't want to go back and again ask the question of fixed duration versus until progression. However, things have changed with triple and quadruple therapy, mostly quadruple, because now elderly patients do achieve minimal residual disease negativity. So my provocative question is, in patients who achieve minimal residual disease negativity, should we continue treatment for 5, 6, 7 years, which might be possible in a rich country like the United States, which will not be possible in a poor country like France, and which will be even less possible in poorer countries. So, of course, I think I always ask this question of the duration of treatment, but it might be possible to ask it now that we achieve MRD negativity in a good, reasonably good proportion of patients.
Thank you, Jean-Luc. That sounds like music to my ears. Saad.
All right, so I can take this. I think this is very important, and this is where trials like Midas will come into play. One of the very important lessons is one-time MRD negativity is not sufficient. We need sustained MRD negativity for disease control in patients, whether they're younger, whether they're older. But what about patients who are able to achieve MRD negativity at 10 to the -6 even after induction cycle? Do we need continuous therapy for those patients? And our next group of clinical trials, we really need to think about 10 to the -6 as that decision tree and start asking these questions. I know we are compelled to do certain trials for registrational purposes, but to truly get to the heart of what, to Jean-Luc's question, if we get patients to 10 to the -6 with that initial induction treatment, we should be able to pare things down and give less drugs to certain group of patients. And those are the trials we need to do. And that is how we'd be able to, get better disease outcomes for patients throughout the world. Yes, it's going to be pricier than what we have now, but if you look at the societal benefit, that would be much greater. That's just my view, and I would welcome comments from Thierry as well.
No, I agree. 10 -6 in Cepheus and IMROS is a little bit, is 40-45% of patients, which, and as you say, Jean-Luc, that's a pretty good number of patients, in fact, and sustained MRD negativity at 10 -5 is almost 50% of patients. So that I fully agree that we should find a way to discontinue in a, let's say, in a clever way, and patients will not have to stay continuously on treatment for. I have Maya patients receiving currently cycle number 120, but the majority of these patients receive daratumumab only, and to be honest, they are fine because they get one sub-Q of dara every month, but the cost is important. You may generate adverse events in some patients, etc. So we will need to discontinue, and that will be likely based on MRD, because it's, as you said, we have now a fair number of patients MRD negative. So
thank you, Thierry, because this is exactly, and I'll move now to the relapse refractory setting. This is exactly what has been done with belantamab. And this is an antibody-drug conjugate. We had the release of the DREAM7, DREAM8 trial. I kindly remind you, belantamab plus bortezomib dexamethasone, or belantamab plus pomalidomide and dexamethasone, showing superiority, being brave enough to compare 3 triplets head-to-head against Dara-VD. You may still say that Dara-VD is not standard of care. But beside the great results, I think the beauty is that now you can give belantamab every 3 months. And it looks like patients are loving this. So can someone, Lisa, I don't know if you can comment on this, Meral, Nizar, whoever wants to jump in, and let's address now the relapse refractory setting, and starting with belantamab because of this issue of convenience and having longer cycles, easy, more friendly user, I would say, treatment approaches. Meral.
So we have participated in the DREAM8 study, and it starts from after first relapse up to 3 lines of therapy. And so far, I mean, all through the patients that we included, we have observed ocular toxicity. But once you have a ophthalmologist whom the patient sees so frequently, even before a patient has any complaints, the ophthalmologist tends to detect some changes in the ocular exam. Of course, that was a precaution that made us interfere with the dosing and the dosing intervals. And my experience is that even if we gave like 3 months interval, we didn't lose the response, the depth of response that was achieved. So it seems that these monoclonal antibodies have a more persistence than we think in the beginning. And I think the dosage, which was initially 2.5, so step by step, and decreasing the dose didn't really have a negative impact. So I think we are learning, such as what we did with bortezomib. Bortezomib was 1 for 8, 11 for everybody, and now it's more for most of the people. It's once weekly, and even it was 1.5 for a period, and now it's for all 1.3. I think we are going through a learning phase for this new drug, but I have also to mention that the T cell fitness is not a requirement for this type of drug, which might be also very helpful. And for elderly patients, it is very good to have a drug that you can administer with once every 2 months or maybe every 3 months, less frequent hospital with a single drug. It could be possible.
Lisa, what is the experience in Germany and in your center eventually?
Yeah, I totally agree. I mean, even though we did not actively recruit patients into DREAM8 or so, we have much experience with belantamab from before, and now seeing the data that eventually the dosing is going to a more like Q12 weeks cycle or frequency. That's very convenient for many patients, particularly also for patients coming off of a Dara-RDEX regimen, for example, the older ones, or of Dara-R maintenance, when you're looking to introduce something else like BCMA targeted therapy, and then in combination with proteasome inhibitor or the oral regimen with Pomdex. So I do think that we, as Meral said, we have undergone a huge learning curve and are still undergoing it, and that even the current dosing will probably not be the final one.
Yeah.
Excellent, thank you. So Nizar, let me put this belantamab story in the global perspective about the anti-BCMA directed therapies. And here we have belantamab, antibody-drug conjugate. We have the bispecifics, teclistamab, elranatamab being approved in many places. And we have, of course, the CAR T cells, namely ide-cel and cilta-cel. And of course, we won't be able to solve the question on how to choose among them, but obviously, from an immunological standpoint, the story can be different. One of the beauty of the CAR T cell, it's a single-shot treatment, then wait and watch. Although the trials in the frontline are using maintenance after CAR T-cell, which is against the dogma. So here, in your opinion, what do you think about the sequence of these different treatments? Because patient can receive bispecific after an antibody drug conjugate or vice versa. Also, there are some concerns actually, and the paper was pre-published during IMS about this large series from the US. This is in Blood by Dr. Doris Hansen, looking into cilta-cel in the real world, confirming the great results, which we already knew, but raising some concerns or question marks, let's say, about some safety issue, neurotoxicity, MNTs, mild neoplasm. What's your take on all this?
Thank you, Mohamad. It's a challenging question to answer. As you said, we have ADC-based therapeutics, we have CAR T-cell therapies and bispecific antibody. The question is, there benefit from one type of therapy over the other in certain subpopulation? Unfortunately, we have no head-to-head comparison, but we can make some conclusion based on some biological models and some of the clinical data presented. If we look at patients who have high-risk cytogenetics, as I mentioned earlier, for example, that seems to still impact CAR T-cell therapy outcome. Well, doesn't seem to be the case in bispecific antibodies. Biologically, I don't know why that this observation is as it is. One possible postulation that with bispecific antibody, we give them continuously, and hence, as we learn with high-risk disease, we need more continuous and sustained therapy. So maybe that's the difference, while CAR T-cell therapy is only one-time approach and done. So for example, if I have today somebody with high-risk disease, I would favor to use bispecific antibody for that reason. On the other hand, if you have somebody with very high disease burden, that's to be the reverse case. In this particular case, CAR T-cell therapy seem to perform better with high disease burden as opposed to bispecific antibodies. And you can argue on that, and we don't know why again, but possibly because CAR T-cell can expand to a dramatic number of millions and billions of T cells, and that can perhaps overcome or skew the ET ratio, effective ratio, in favor of the immune effect. And then in this population, I may favor a CAR T-cell therapy. Beyond that, I think down the patient preferences, patient always favor one-time approach and done. But as you said, unfortunately, we're now modifying this CAR T-cell therapy to also add to it. So maybe it's not going to be a one-time therapy and done. As far as sequencing therapies, we've had a few studies suggesting that the use of bispecific antibodies or ADC before CAR T-cell therapy may limit the efficacy of CAR T-cell. This also is coming into question now with some clinical trials using limited number of bridging therapy with bispecific antibodies, suggesting it may not necessarily be the case. And as you mentioned, the paper by Hansen and colleagues, she showed that patients who have a washout period of 6 months, there's no impact appears to, so apparent impact of bispecific antibody prior to CAR T-cell therapy. So again, we need more data, we need more experience to really understand the better sequence. But for now, I guess if somebody has to decide based on therapies we have, I would say yes, to try avoiding bispecific antibody before CAR T-cell therapy. And lastly, as you mentioned, Mohamad, the safety issue with CAR T-cell is not fully resolved. Unfortunately, we are seeing myeloid malignancies, we are seeing neurotoxicity with CAR T-cell therapy that someone needs to take into account, especially when discussing the therapies with the patient.
By the way, it wasn't in myeloma, but there was this week, last week in the New England Journal of Medicine, a beautiful paper by Dr. Guido Kobe and colleagues looking into lymphoma after CAR T-cells. So the story is still ongoing, I would say. So Aurore, because I think the recommendations of the IFM are always eagerly awaited by the community. So do you think, despite whatever has been said and we read, we should stick into our global recommendations in France, whenever possible, try to give CAR T-cells, and then we think about the other options, or you're willing to modify your approach?
It's a good question. I think it is always difficult to make guidelines, specific guidelines in France in the relapse setting. So as you know, we have access only to IDECEL. The early access, according to KarMMa 3, has been interrupted, I would say, but we can, in some particular cases, propose to patients with a triple refractory myeloma in first relapse. So it is a little complicated, I would say, today. I think we discussed with colleagues to propose CAR-T as soon as we can, but I'm not sure that we will be able to do specific guidelines.
Thank you. So as a disclaimer, the paper in Blood is related to cilta-cel, and so these safety issues were not raised with ide-cel, which may be a good option in some elderly patient if we are fearing some toxicities. But Saad, what is your approach in New York? Who is getting CAR T cells and on which criteria?
So right now, with the change in the indication for the early line patients, we are choosing functional high-risk patients because for other patients, we have good triplet options. And I think you did mention the belantamab mafodotin triplet data, and we are hoping that will also become an important option for our patients in the near future. I completely agree with you. I think the proposition of CAR T cell therapy in patients, who may be a little older is a little bit different. And this concern primarily around, the second primary malignancy issue is something that we have to carefully examine and really look at the, benefit and risk of, which patients do we, get CAR T early versus late. Because looking at the PFS data, they kind of look similar from both the early versus late setting. So for functional high risk, I'm comfortable in offering that to patients.
Excellent. So we still have another 3 minutes in this webinar, and I would like to get your final thoughts. Now, after IMS, what is your wish to the field? So Thierry, for the elderly non-transplant eligible population, what are the next steps in your opinion?
No, that's a difficult question. I think the next step is what I will say is not okay. It's not very unexpected. I would say we have ongoing studies with both bispecific antibodies and on CAR T in a way. We still have to work a lot on this because back to the discussion on belantamab, the switch from belantamab every 3 weeks to every 12 weeks took 5 years or so. And currently we have bispecific, they started every week. Then they said, okay, it's good every 2 weeks. Every 2 weeks is a lot of injections. So bispecific will likely may go every 8 weeks or even 12 weeks as well. So the regimens we have today with bispecific are far from perfect. And I think that will change a lot. The way to handle CAR T strategies in elderly, back to the point of raised by Saad, is what is exactly the risk versus the benefit. So would you prefer to manage a quad regimen and to discontinue in MRD negative patients, for example, or would you prefer to take the risk of a CAR T strategy, which will provide a treatment-free interval, but then we don't have data for that. So I think we have to work on the use of the best possible way to use bispecific antibodies and also the way to manage CAR T strategies in elderly. That will take time from my point of view. But if you ask me what would be a good regimen for elderly, I could tell you, for example, if you can manage a bispecific antibody in combination with a CD38 given every 12 weeks or 8 weeks, which means every 12 weeks means 4 times in a year. If you can achieve MRD negativity in this way, that could be a good achievement for elderly. So, okay, but that will be for the young. That will be for Lisa and the young hematologist here, Aurore, and okay. Not for you, Jean-Luc, not for me, so they will do.
No, but we still need your wisdom, guys. Jean-Luc.
As Thierry just said, it will be difficult for me to see the results of ongoing trials because especially for newly diagnosed patients, the median progression-free survival is being so long, even in elderly patients, that we have to wait. And I think that I would prefer to make a comment regarding this particular IMS meeting, because in my opinion, that was really a path forward. It's a new way of organizing the IMS meetings, because for the first time we had really new data and we had presentation of unpublished clinical trials, the Aurore, the Cepheus trial, which is really absolutely important because it's not only a meeting for didactic purposes or even for discussion, but it's also now a meeting for learning and hearing new data. So if I can attend the next meeting, the IMS next meeting, I would be happy to see the improvements in the bispecifics that you've just alluded in. It's really a fantastic adventure, and I'm so surprised that belantamab is going back, that we have other possibilities, and for you young doctors, it will become very difficult to choose the best strategy for a given patient, which is good for the patient. There are more possibilities, of course.
Thank you, Jean-Luc, and obviously we are very eager to see you in Toronto at the IMS, and I must confess I agree with you that Dr. Vanya Hungria and Anjali Maiolino did really a fantastic job in Rio. Meral.
So I think what we owe today in myeloma is the event of new targets and the immunotherapeutic targets, and also the mutational signatures that is now appearing. And so these two authors here, Saad's group and Nizar Bahlis, has contributed so much to this field. But I having a myeloma, a very moving target possessing the disease, we need to go to the upstream rather than going downstream and having a target which can be mutated, which can be lost, but going to the genomic instability, the apopex signature, maybe, because during the meeting, Saad's group showed the special heterogeneity in the EMD versus the marrow, the differences in between. So if you have one target in the marrow but not in the EMD, what use of that targeted therapy? So I think these are the issues, maybe hopefully will be solved in future with your help. And if we can solve why genomic instability is the leading role player in myeloma, that could be a real game changer.
Thank you, Meral. Aurore, any thoughts after Midas?
I would say that I think we are lucky to treat myeloma patients today. We have a lot of options. And my hope for the future is that we will have more biologic rationale to use the best treatments according cytogenetics, but also immune system, etc., and to do more smart decisions. Not only quadruplets for all, but it is a good thing to have quadruplets for all.
New era of personalized therapy. Lisa.
Yeah, exactly. So by now, I think it's really time to sort of go into the personalization, and not just by genetics, by risk, but also by frailty, by age, but also, and most importantly, by accessibility. And I think there it is key to actually make all these treatment and innovations accessible to all patients worldwide and in a timely manner. So that would be another big step forward for the myeloma patient world.
Excellent. Saad?
I would agree with all the, comments made by my colleagues. In addition to what's already been said, I'm very hopeful about the future of all myeloma patients, including the high-risk patients. As we start narrowing down that definition, I think we can have more concerted efforts on how to overcome that, high risk of disease relapse and death. And I think we are more aligned today than we have ever been. So I'm very hopeful for the future.
Superb. Luciano?
I think you're looking at vision for the future. I agree. I think I think there's some things that are very new and in a way unprecedented in myeloma. I think overall the evolution has been to add something with a small incremental gain to what is already established. But I think for the first time, at least in my career, we have agents and therapies that by themselves perhaps are more active than prior combinations that we have had in the past. So I think we need to challenge a little bit of our mindset and start to design more innovative trials that really try to make the best use of those transformational agents up front, aiming for I think the high risk population, the ones who don't do well, always captivate our imagination and drag our attention because they're the ones who need the most need. But separating this population is very crucial, so we don't quote unquote punish those who might be cured already with existing therapy with excessive treatment while we try to pursue an improvement with a high risk. I think we need to better find the definition and the path to discontinue therapy. What I believe is maybe as much as 50% of the patients who might be curable with the therapies that we have, and be able to design trials that are more properly focused on the high-risk subset. So, of course, having a uniform high-risk definition is instrumental, but is only as good as our willingness to deploy that on trial design, not just be a reflection on existing clinical trial data, but embrace the definition and start designing a specific trial for that population.
Excellent. So Nizar, you have the last word.
Thank you, Mohamad. I don't have much more to add to my colleagues. I'm going to say that we're living in a very privileged era where we have very effective therapeutics. And with that comes I should say, a professional responsibility not to apply all these therapeutics blindly to all patients, because I'm afraid we are in the era of Hodgkin lymphoma and ALL, where we have this 80-90% response rate, and adding more therapeutics bluntly to everybody may cause more harm, at least to some subgroup of patients. On the other hand, we have a tremendous understanding of disease biology and technology to help us dissect the biology of the myeloma. So I hope in the next meeting in Toronto or the next few years, we'll see more integration of this biology with the therapeutic decision-making to hopefully avoid the harm and continue to provide the benefit to our patients.
Well, superb, guys. You did really great. We are a little bit above time, but I think everybody has enjoyed it. Thank you so much for sharing your knowledge, your wisdom. Thank you for a fantastic summary of this International Myeloma Society 20th annual meeting held in Rio de Janeiro earlier in September 2024. I hope everybody has enjoyed this discussion. And wherever you are, please stay safe and keep well. This is the ICH with you all the time. Thank you.